Okay, this is our third lecture I'm thinking it's going to be more like 6 or 7 um, presentations to cover the cardiovascular disorders and the cardiovascular dysrhythmias. So we're going to start looking at rhythm strips here. And we've already talked a bit about the anatomy and pathophysiology of the heart and the heart's electrical conduction system and the heart monitor and the ECG paper. Now we're going to start discussing how to identify and interpret the rhythms that you see on the monitor. So I think it's important that when we learn rhythms that we begin with what is normal. I find it very difficult to pick out abnormal if I don't know what normal looks like. And what we're going to learn is that arrhythmias or dysrhythmias, whichever term you like to use, they all have rules. They have a set of things that they must meet in order to be called what they're called. And this will all make sense as we get further into this. So let's start with normal. A normal rhythm starts in the SA node, the sinoatrial node. And when looking at a rhythm, a normal rhythm should have a positive upright P wave in lead 2. And there should be one before every QRS complex. The P waves should all look alike. The PR interval should be constant. The rhythm should be regular. Both the atrial rhythm and the ventricular rhythm should both be regular. So measuring P to P, that should measure out nice and regular. Measuring R to R, that should measure out nice and regular as well. So a normal sinus rhythm, and some people will call it a sinus rhythm because they don't believe that everything is normal. Some people will call it a regular sinus rhythm. So it's called a variety of different things, but sinus rhythm, the rate is normal. It's between 60 and 100 because that's typically the rate at which the SA node fires. So the rate's between 60 and 100. The rhythm is regular. In other words, the P to P and R to R intervals are nice and regular, as you see here. The PR interval is less than 3 small squares, and the QRS complex is less than the PR interval is between 3 and 5 small squares, somewhere between 0.12 seconds and 0.20 seconds. And the QRS width is less than 3 small squares, or less than 0.12 seconds. The P wave should be positive in lead 2, and we're going to learn all our rhythms that we look at in this lecture series as if we're looking in lead 2, and the vast majority of people will look at lead 2 as their standard lead. As you learn more about rhythms, there might be a need to look at AVF along with lead 2. There might be a need to look at V1 along with lead 2 as well. So it just depends on how your monitor's set up and what leads you want to see rhythms in. But lead 2, the P waves are upright and positive. There's one for every QRS complex. They all look alike because they're coming from the same spot or focus. The PR interval, as I mentioned, should be between 0.12 and 0.2 seconds, and it should be the same from beat to beat. The QRS complex should be less than, they say 0.10 seconds, but I don't know how you split one of those little tiny boxes into fifths. So most people will agree that if the QRS is less than 0.12 seconds or less than 3 small squares, then that's a normal width for that QRS complex. If the QRS complex is wider than that, 3 small squares, then that's telling you there's a conduction delay through the ventricles. And that could be a bundle branch block, and that's typically what that is. A bundle branch block will cause that. Or the complex itself is originating in the ventricles rather than being generated from the SA node. If the PR interval is longer than 0.2 seconds or longer than 5 small squares, then that's an indication of a first-degree AB block. Now, sinus rhythms are normally 60 to 100, but they can be slower, sinus bradycardia, or faster, sinus tachycardia. And certain things will affect your heart rate. Medications that you may take, particularly calcium channel blockers, beta blockers, digitalis, those sort of things are going to decrease your heart rate. Diseases or conditions will also cause an increase or a decrease in heart rate, or cause the heart to beat irregularly. And that would be things like atrial fib, that would be things like premature beats, whether they be PACs, PJCs, or PVCs, can all cause your heart to beat irregularly. And then you can have diseases or conditions that will delay or block impulses from leaving the SA node. And those would be like your second degree type 1 and type 2 heart blocks, and your complete heart blocks, or your third degree heart blocks. In sinus bradycardia, the rule here is that the SA node fires at a slower rate than normal. And in adults, we say anything less than 60 is bradycardic. So this would be an SA node that, for whatever reason, is firing less than 60 beats a minute. Everything else about the rhythm would be normal. There would be an upright P, there would be a QRS, there would be a P for every QRS, the PR interval would be within normal limits, the QRS width would be within normal limits. It's just that the rate is slow. And that's what they're identifying here is the rules. A sinus bradycardia is a sinus bradycardia when the rate is less than 60, when the rhythm is regular, your P to P is regular, your R to R is regular, when the P waves are upright in lead 2, and there is one for every QRS complex, and they all look alike. The PR interval is normal, the QRS width is normal, and that's what's demonstrated in this rhythm here on the slide. You can see that the rhythm is regular. The rate is, using a variety of different methods. I like to use the 300, 150, 100, 75, 60, 50. This rate is 50. And you'll get comfortable with, either counting the number of large boxes and divided that into 300, or count the number of small boxes and divide that into 1500. Or if this were a 6-second strip, if each one of those little tiny black ticks on the top of the paper represented 1 second, then if this were a 6-second strip, you could count the number of complexes, 1, 2, 3, 4, 5, and know that the rate was 50 as well. So there's a variety of ways that you can determine the rate, but the rhythm is regular, the rate is 50, there's a P for every QRS, the P to P is regular, the R to R is regular, the PR interval is within normal limits, and the QRS width is within normal limits. So everything about this is okay, except it's slow. Now when we start naming arrhythmias, I had mentioned that the first name usually tells you where it's coming from, and the second name tells you what it's doing. So when I look at this and I see sinus bradycardia, that tells me this rhythm is originating from the SA node, and I know that because there's an upright, nice, rounded P wave for every QRS. And then it tells me what it's doing. It's bradycardic. It's less than 60. Okay? So that might help you when you start looking at rhythm strips and you're trying to identify or name them. Kind of remember the first name tells you where it's coming from, and the second name tells you what it's doing. Now, typically, you need to look at the rhythm, the sinus bradycardia, and if it's symptomatic, we might have to treat it. Sinus bradycardia exists in athletes. Sinus bradycardia exists in people who take certain medications, and for some, a heart rate of 40 isn't going to cause any symptoms. So if there are no symptoms, there's no need to treat it. However, if there are symptoms, and the symptoms that we look for are things like chest pain, things like a drop in blood pressure, things like pale, sweaty, altered level of consciousness, those sort of things would be symptoms. And if they are symptomatic, we need to treat it by increasing the heart rate. And there's a variety of ways that we can do that depending on what's causing the heart rate to be slow. Here they list certainly oxygen. If their SATs are less than 94% and they're complaining of shortness of breath, you want to gain IV access because you'll have to give medications. You may even have to pace the heart from outside the body. And one of the first medications that we give for all symptomatic bradycardia, regardless of the cause, is atropine. And you'll learn about atropine, if you haven't already, as one of your drug quizzes. You'll learn a lot about it in ACLS. Now, sinus tachycardia is just the opposite. Instead of it being too slow, this is a rhythm that originates in the SA node, but it's beating too fast. So sinus tachycardia, by definition in this book, is a rate somewhere greater than 100, like 101, all the way up to 180 beats a minute. Now, you know, the SA node typically doesn't beat faster than 160, but they're taking it all the way up to 180 in this particular book. So somewhere between 100 and 180, or 101 and 180 would be considered sinus tachycardia if you can see the P waves. Remember that when rhythms get going really fast, everything gets closer and closer and closer on the paper. And as you'll see when we talk about supraventricular tachycardic rhythms, you may not be able to see the P waves when they get beating 180 beats a minute. So the rate is between 101 and 180. The rhythm is nice and regular. The P to P is regular. The R to R is regular. There's an upright P wave in lead 2. There's one for every QRS. They all look alike. And again, at really fast rates, with everything scrunched together on the paper, it's going to be difficult sometimes to differentiate P waves from T waves. The PR interval is normal, and the QRS width is normal as well. So this rhythm here on the slide illustrates the rules of sinus tachycardia. The rhythm is regular. The rate is 300, 150, 100. The rate is 140. There is a P for every QRS. The P's are nice and upright. The PR interval is within normal limits. The QRS width is within normal limits. So everything about this is okay, except it's 140 a minute. So we would call this sinus tachycardia. Now, sinus tachycardia can be caused by a lot of things, and it becomes our responsibility when we're assessing a patient who has a rate greater than 100 to see which of these things are present, and if we can fix it, then that's certainly something we would do so that the heart rate would return back to normal. When you exercise, your body calls for more blood, more oxygen, and so you not only increase your rate and depth of breathing, but you also increase your heart rate to increase your blood pressure, to push more blood to your tissues. Fever will cause an increase in heart rate. Pain causes an increase in heart rate. Fear and anxiety. Lack of oxygen causes an increase in heart rate initially, but then eventually the heart rate starts to slow down if you're hypoxic for long periods of time. Congestive heart failure can cause an increase in heart rate, particularly uncontrolled atrial fib or atrial flutter. Acute MIs, anterior, large wall anterior MIs can cause rapid heart rates. Infections or sepsis will cause rapid heart rates initially. Sympathetic stimulation. When you stimulate that sympathetic nervous system that we talked about quite a while ago, the fight or flight nervous system, when you stimulate that, adrenaline, norepinephrine, and dopamine are released into your bloodstream, and all of those hormones causes an increase in heart rate, increase in strength of contraction, as well as some vasoconstriction, all in an attempt to raise your blood pressure or keep your blood pressure up. Shock will cause an increase in heart rate as a normal response to low blood pressure or low cardiac output. Dehydration, pulmonary embolism, hyperthyroidism. Medications will increase heart rates. We use medications like epinephrine, like norepinephrine, like dopamine to increase heart rates when they're too slow and we can't get them increased with pacing. Caffeine-containing, nicotine-containing products, and certainly designer drugs like methamphetamine, bath salts, K2 spice, all that stuff, ecstasy, they all increase the heart rate. The thing to keep in mind about sinus tachycardia is that most of us can handle a heart rate, in the 120s, 130s, even the 140s. But if you've got somebody who has a sick ticker, they've got heart disease, and their heart rate's beating 140 a minute, the faster your heart beats, the less time your ventricles have to fill. And so the less blood they're pumping out. So what's interesting about an increase in heart rate is that, when you go into shock, your body's compensatory response is to increase the heart rate. And initially, increasing the heart rate does increase and maintain the blood pressure. But if the heart gets beating too fast, it actually moves less blood because the ventricles don't have time to fill. And this is going to result in a decrease in cardiac output and a drop in blood pressure. Sinus tachycardia can be a warning sign for heart failure. It can be a warning sign for all types of shock. One of the first early indicators of shock is tachycardia. It can be a warning sign of an arrhythmia, and it can be a warning sign for sepsis. Sinus arrhythmia is a normal finding in patients, and it's usually related to inspiration. What you see on the monitor is that when a person takes a breath in, their heart rate slows down, and when they exhale, it speeds back up again. And this is a normal finding. It doesn't require any treatment, but you'll see it in patients, and it's related to an increase in intrathoracic pressure. When you take a breath in and you increase intrathoracic pressure, it has a tendency to slow the heart rate down. With a sinus arrhythmia, the rate's going to be normal between 60 and 100. The rhythm is going to be irregular, but you can time it with breathing. That's the key here. The P waves are going to be upright and lead 2. There's going to be one for every QRS. They're all going to look alike. The PR interval is going to be normal, and the QRS duration is going to be normal as well. So here you can see at the T wave of the very first complex, there's quite a distance. Then the heart rate speeds up, and then it starts to slow down again towards the end of this strip. And if you ran a really, really long strip, you would see a wallpaper pattern. You would see a pattern of speeding up, slowing down, speeding up, slowing down, and it would all be tied to their inspiration. Sinoatrial block. Sinoatrial block, the SA node initiates an impulse, but it's blocked as it exits the SA node, so it doesn't travel the internodal pathways, and it doesn't cause a contraction of the atrium. Oftentimes with sinoatrial block, the rhythm will return to normal once that skipped beat is passed. Causes of sinoatrial block include acute coronary syndromes, which are angina, unstable angina, NSTEMI and STEMI, medications, coronary artery disease, myocarditis and inflammation of the heart muscle itself from disease or injury, heart failure, carotid sinus sensitivity. Your carotid arteries, if you massage those, not recommending that you do, but a carotid sinus massage will increase the release of acetylcholine by the vagus nerve. And when acetylcholine gets into the bloodstream, that's the parasympathetic nervous system being stimulated, and that's going to cause a decrease in your heart rate. And that's increased vagal tone as well. With sinoatrial block, the rate is usually normal, but it's going to vary because there's going to be that pause where an impulse should have happened but didn't. The rhythm is irregular because of the pause, but the pause is same as the distance between any two other P-to-P intervals. So even though we're missing a PQRS, everything still marches out, as you'll see here. The P waves are positive in lead 2. There is one for every QRS complex. They all look alike. The PR interval is normal. The QRS width is normal as well. So as you look at this rhythm, you can see this pause in the center of the strip here, where there should have been a P and a QRS and a T. The T waves in this particular rhythm, aren't very identifiable, but they are there. They kind of dip down below the isoelectric line in the third and the fourth complex that you see, but they're there. But we're missing a beat. But if you measured R to R to R all the way across the paper, those R's, P's, and QRS's that occur on the tail end of this strip measure out the same distance as the ones that are on the front of the first part of the strip. So the SA node fires, but it never gets out, so there is no P wave, there is no QRS, but it really doesn't affect the rest of the next firing of the SA node. Sinus arrest occurs when the SA node fails to initiate an electrical pulse for one or more beats. So there is no PQRST as well. The rate is usually normal. The rhythm is irregular because of the pause. The pause is going to differ depending upon how long it takes the SA node to fire again. The distance between the P to Ps and R to Rs is not going to be the same like it is in the previous sinoatrial block. P waves, when they are present, are going to be upright. There's going to be one for every QRS. They're going to look alike. The PR interval is going to be normal. The QRS width is going to be normal. So what you'll see here, which differentiates a sinus arrest from a sinoatrial block, is the pause. In a sinoatrial block, the rhythm is not affected. In a sinus arrest, if I were to march out my R to Rs, they don't match up on the back side of this, or the later far right. Those complexes on the far right of this strip aren't in sync or in line with those on the left, and it's difficult for me to demonstrate this on the slide. You would just have to take and measure on a piece of paper, put a notch on the piece of paper above 2 consecutive QRS complexes, put notches on the paper, put a mark on the paper where those are, and then just slide those across the strip and see if the next QRS complex stays in line with those, and slide that all the way across the paper, and that's how you're going to differentiate a sinus arrest from a sinoatrial block. Sinoatrial block is usually one missed complex. A sinus arrest could be 2 or 3 or 4 missed complexes. Causes of sinus arrest: hypoxia, acute coronary syndromes like angina, unstable angina, NSTEMI and STEMI, hyperkalemia, digitoxicity, medication reactions, again, increased vagal tone or carotid sinus activity. Now, P waves reflect the atrial depolarization, and we know that when we see a P wave on the strip that is upright in lead 2, that the atrium have depolarized. But something to keep in mind is that if the SA node chooses not to fire or is slow in firing, any cell outside that conduction network, any cell could initiate a spark by itself and cause a depolarization of the atrium. But what you'll see here is that the P wave is shaped differently than when it is originating from the SA node. It may not necessarily be upright and rounded. It may be peaked. It may be biphasic, some above, some below. But it's going to be shaped differently, and that's how we know it's not coming from the sinus node. It's not nice and round and upright, and as we've seen so far. So as an example here, we're going to talk about some atrial dysrhythmias, arrhythmias that originate in the atrium. And the first one we're going to talk about are PACs. And if we break that down, a premature atrial complex, well, premature, it's got to be a complex that comes early. Atrial, it originates in the atrium, so there will be a P wave, but it may not look like the rest of them. And it's got a QRS complex with it. And when we see PACs, that tells us there's an irritable site within the an irritable site within the atria fires before the next SA node impulse can get out. It's going to interrupt the sinus rhythm, and again, the P wave is not going to look like all the other P waves. So if you look at this strip here, you can see the second complex, seventh complex are premature. They come early. And we also can see that the P wave before those complexes is quite pointed and doesn't look like the other P waves in the preceding QRSs that are nice and round and upright. So it's quite peaked. And that's how we know it's a PAC. It has a P wave. It comes early. And that's what makes it a PAC. The rate is usually within the normal range, and it's going to depend on the underlying rhythm. PACs occur in all of us all the time. The rhythm is going to be regular with a premature beat. The P wave is going to come early in a PAC. It's going to be upright in lead 1. There's going to be one for every QRS. It's going to differ in shape from the regular sinus P waves. It may be flattened, notch, pointed, biphasic. It may be lost in the T wave. The PR interval is going to be normal, and the QRS width should be normal as well, unless, of course, there's some sort of bundle branch block. And it's important to note here that the QRS should look pretty much the same as all the other QRSs, because once that premature site fires in the atrium and passes that electricity from cell to cell to cell to cell, causing both atrium to contract, that impulse is going to end up at the AB node, and then it's going to go through the normal conduction pathway after that. So the QRSs should look like all the other QRSs. The QRS of the PAC should look the same as all the other QRSs. PACs can come in pairs. They can come in runs or bursts. They can be every other beat, every third beat, every fourth beat. We don't see this very often, but the more frequent a PAC is, the more irritable the atrium are. And if the atrium are irritable, certainly they can cause tachyarrhythmias as well as AFib aflutter. Now, aberrantly conducted PACs, aberrancy means that the electricity takes an alternate route. And with aberrantly conducted PACs, the PAC occurs early, but the right bundle branch is slow to respond. So because of that, you've got the premature site, or the site in the atrium, firing prematurely. It goes through the cell to cell to cell to cell, causing a contraction of the atrium, ends up at the AV node, but because it was premature, as it passes through the bundle of His and down the right and left bundle, it may be slow to conduct down the right bundle. So you get a contraction of the left ventricle before you get contraction of the right ventricle, and it causes the QRS to be notched or wide. Okay? So you can see here that the third and the fifth beat in this rhythm, the third beat is premature. The P wave is in the T. They're pointing to it there. The P wave is in the T. But it's aberrantly conducted because look at that QRS. That QRS doesn't look like the second PAC QRS. It's wide. It's got a little notch in it. And that's because that PAC was aberrantly conducted. Where the second PAC, where the arrow identifies the P wave on top of that T of the preceding beat, that QRS looks like all the other QRSs because it wasn't aberrantly conducted. Non-conducted PACs, you're going to get a P wave, but you're not going to get a QRS. And that results from the AV node, which is the gatekeeper to the ventricles. Remember that the AV node is the gatekeeper to the ventricles. If that, if a spot on the atrium fires early and causes both atrium to contract, and that electricity gets to the AV node, it's going to hold on to it and then decide whether it's going to let it go through or not. If it goes through, then you'll get a normal QRS unless it's aberrantly conducted like we just talked about. But it may choose not to let it go through. It may say, it's not time. I'm not ready to let this go, and it won't let that impulse go through. So you'll have a P wave, but you won't have any QRS. So that's a non-conducted PAC. And if you look at that third beat, if you look at the T wave of that third complex, you had a PQRST, PQRST, PQRS, and the T looks different than the other T waves. The T looks different than the other T waves. It looks a little broader on the top, and that's because there's a P wave in there, a premature P wave that didn't generate a QRS. Now, PACs are often benign. As I had mentioned, we throw PACs all the time. Some causes of PACs include emotional distress, heart failure, acute coronary syndromes, mental and physical fatigue, atrial enlargement, and you get atrial enlargement particularly on the right side of the heart from things like pulmonary hypertension. Valvular heart disease, digitoxicity, electrolyte imbalances, imbalances in your sodium, potassium, or calcium, hyperthyroidism, stimulants, caffeine, nicotine will all cause PACs. And again, as I had mentioned, they're normally benign. If they are bothersome because they're coming real frequently, particularly in the case of stimulants, if you're drinking a lot of caffeine and you can feel a lot of irregular heartbeats, then you just eliminate the caffeine, and when that is metabolized out of your body, those PACs go away. PACs can cause the onset of really fast heart rates, and typically that is what causes the onset of a really fast heart rate is a PAC. Now again, they don't require treatment if they're infrequent, but if they're frequent, as in the case of atrial fib or atrial flutter, or the case of paroxysmal supraventricular tachycardias, then we need to perhaps slow the rhythm down and correct the underlying cause of the PACs. A wandering atrial pacemaker. What happens here is multiple sites on the atrium take turns firing, causing the atrium to contract. But because there are multiple sites taking turns, the P waves all have different shapes and may have different directions. Some may be above, some may be below, some may be biphasic, and it varies from beat to beat. In order for you to have a wandering atrial pacemaker, you have to have identify three different types of P waves in the same lead. Usually there are no signs and symptoms, and the only way a person knows they have a wandering atrial pacemaker is they're hooked up to a heart monitor. The rate is usually normal. It may be a little slow. If it's greater than 100 a minute, then the P waves are coming from multiple sites. The rhythm may be irregular as the pacemaker shifts from the SA node to that ectopic spot, that irritable spot on the atrium, or those multiple irritable spots on the atrium begin to fire. The P waves, the size and shape and direction change from beat to beat. Again, you got to have 3 or more different looking P waves in order to have a wandering atrial pacemaker. The PR interval is going to vary. The QRS width should be normal unless there's some sort of delay. And as I look at this rhythm, you can see that the first 2, 3 P waves look the same, and then you got 1, 2, 3 that are inverted. 4, 5, and 6 are inverted, but some of those inversions look different. Some are rounded, some are pointed, and then the P wave in the second to the last complex isn't upright and rounded like it is in the first 2 complexes. So you've got multiple looks here of P waves, and that would just tell you that perhaps the first and second and third beat are coming from the SA node, where all the others are coming from different sites on the atrium. Multifocal atrial tachycardia, it's a multiformed atrial rhythm with ventricular rates greater than 100. And this is a result of multiple spots on the atrium taking turns firing fast. Conditions include severe and chronic obstructive pulmonary disease will cause this, hypoxia will cause it, acute coronary syndromes, digitoxicity, rheumatic heart disease, theophylline toxicity, electrolyte imbalances. And that's one thing. Anybody who takes digoxin, anybody who has issues maintaining normal sodiums, potassiums, calciums, can have all kinds of different arrhythmias, because many arrhythmias are related to digitoxicity or electrolyte imbalances. And that's why many people who used to take dig are taking things like calcium channel blockers now, because they're more effective with fewer side effects. If you have multifocal atrial tach, you want to treat the underlying cause. Certainly if the heart is fast enough, if the rate is fast enough, you might try some vagal maneuvers, have them cough or bear down, which stimulates the vagus nerve, releases acetylcholine, and acetylcholine causes the heart to slow down. Or you may have to give a drug called adenosine. 6 milligrams rapid push, wait a couple minutes, 12 milligrams rapid push. If that doesn't work, you may have to synchronize Cardiovert. So here's an example of multifocal atrial tachycardia. The rhythm is quite irregular. It is greater than 100. The P waves don't all look alike, and depending on which one fires when, you may have some pauses in this rhythm, as you see here. Supraventricular tachycardias. Supra means above the ventricles, and these begin above the bifurcation of the bundle of His. So they could be in the AV node, they could be anywhere in the atrium. They're typically not coming from the sinus node. Supraventricular tachycardias aren't coming from the sinus node because the sinus node usually doesn't beat greater than 160. Atrial tach is a type of supraventricular tachycardia. You have one irritable site on the atrium that automatically fires at a rapid rate. And this rapid firing of this irritable site, or this foci on the atrium, overrides the SA node, and this irritable site becomes the primary pacemaker. If you use the word paroxysmal in front of anything, it just means that it suddenly starts and stops. So if you're got the person on a monitor and they suddenly go into an atrial tach, you could call it paroxysmal atrial tach. Characteristically, the atrial tach is greater than between 100 and 250 beats a minute. The rhythm is regular. There's a P wave for every QRS, unless of course the rhythm gets going so fast that everything's close together and you can't see them. The P waves differ in shape from the sinus P wave, so it's not going to be nice and rounded and upright when you do see them. And the isoelectric baseline is usually present between P waves. The PR interval may be shorter or longer than normal. The QRS width should be okay, because once it goes down the bundle of His in the right and left bundle, it should cause a normal contraction of the QRS. Things that will trigger atrial tachycardia include stimulant use, infections, electrolyte imbalances, acute illnesses, heart attacks or acute coronary syndromes. If the event is short, there's just a burst of atrial tach and then it goes away and doesn't come back, obviously there's no treatment. But if it's sustained and they stay at a rate of 200, they're not going to stay in that rate very long. We're going to need to slow that heart rate down. So here is a rhythm down below there that talks about an ectopic site firing anywhere between 150 and 250 a minute. And you can see P waves in here in this tachycardic rhythm, so you know it's coming from the atrium. But if it gets going too fast, as you'll see, we won't be able to see P's or T's, and we're not going to be sure which is which. Atrioventricular nodal reentrant tachycardia, AVNRT. The fast and slow pathways in the AV node form an electrical circuit loop, and as the impulse leaves the AV node, it re-enters into this loop, causing a circus spin-like pathway that results in a very, very rapid heart rate. The rate can be between 150 and 250 a minute. The rhythm is nice and regular. It's hard to see P waves if it gets up into the 200s, 180s. You may not see the P waves at all. The PR interval isn't seen because everything is so close together. The QRS width should be normal because, again, once it leaves the AV node and goes down the bundle of His and through the right and left bundle, conduction through the ventricles should be okay. Some triggers include hypoxia, stress, overexertion, anxiety, caffeine, smoking, sleep deprivation. Certain medications will increase heart rates as well. If the person is stable, let's say they're running a rate of 160, 170, you may give them some oxygen if it's indicated. Their SATs are less than 94%. They're short of breath. Establish an IV, try some vagal maneuvers, and then give the drug adenosine. If they're unstable, their level of consciousness is altered, their radial pulses are absent, we may consider sedation if time permits, but we're going to have to do some synchronized cardioversion to get them out of it. So here's an example of an AV nodal reentrant tachycardia. You can see that the rhythm is nice and regular. The rate is 160 on this particular strip, but I don't know if those are P's on top of those T's or are those just T's. I don't know. It's very difficult to figure that out. But what I do know is that with this rapid heart rate, the QRS width is normal. So conduction through the bundle of His and the right and left bundle in the Purkinje system was normal as well. So this rhythm, because the QRS width is normal, has to come from above the ventricles. Now, because it's nice and regular, that's where you would call it AV nodal reentrant tach. If you weren't sure if this was nice or regular, or you weren't sure if this was AV nodal tach or AV nodal reentrant tach, you could just call it SVT because it is above the ventricles. So you could call this rhythm supraventricular tachycardia. And if you saw it come on and it stopped suddenly and then came back on, you could call it paroxysmal supraventricular tachycardia. And that's what they're saying here, PSVT, paroxysmal supraventricular tachycardia. Because you can see at the beginning of this strip, the rate is 300, 150, 100, rate's about 100, and then it starts to speed up, and there in the middle, the rate's about 300, 150, rate's about 150, 160, and then it slows back down. So this would be paroxysmal supraventricular tachycardia. AVRT, atrioventricular reentrant tach, the impulse begins above the ventricles and travels by a pathway other than the AV node and the bundle of His. So it bypasses the AV node and goes down the right and left bundle and through the Purkinje system. AV reentrant tachycardia is termed a pre-excitation dysrhythmia. The rhythm, again, originates above the ventricles. The impulse travels by a pathway other than the AV node, and as a result, the supraventricular impulse excites the ventricles earlier than what they should, and it causes a rapid heart rate. Wolff-Parkinson's-White, or WPW, is a common culprit of AV reentrant tachycardia. And we'll talk a little bit about WPW right now. WPW, Wolff-Parkinson's-White, does not, the impulse leaves the SA node, but it does not follow through the internodal pathways. It travels through an isolated bundle called the bundle of Kent. The PR interval is essentially non-existent because it goes right from the SA node through the bundle of Kent and into the ventricles. So what you'll see is a delta wave. And a delta wave is a little slurring in the QRS as the R wave starts to rise above the isoelectric line. And then there's a condition known as Long-Ganong-Levine syndrome, where it travels through the bundle of James and bypasses the AV node, and you'll have a very short PR interval, but there won't be a delta wave with LGL. And then Mayheim, you'll have a normal PR interval with a delta wave. So there's a delta wave, and here's an example of WPW, or Wolff-Parkinson's-White. You can see that the P wave, after the P wave, there's an immediate QRS. There is no pause to indicate the AV node is holding on to the impulse for a split second, allowing the atrial kick to occur. So you've got a P wave and then an immediate QRS, so you have no PR interval. Or another way of looking at it is you have a PR interval, but it's less than 3 small squares. So a PR interval that is less than 3 small squares, certainly could be WPW or LGL. And the difference between WPW and LGL is that delta wave. You can see that the QRS looks a little wider as it's coming up from that P. There's a little slur to that QRS indicating an alternate pathway was taken to cause the ventricles to contract. So there's a little aberrancy in the conduction there, which causes a little slur in the QRS. So here's the Long-Ganong-Levine, where you have the P wave and then no delta wave. It looks a little wide on the back side on the S, but there's no slurring of the R wave immediately following the P. So that would be LGL. And I think the thing to keep in mind about WPW and AGL when you see it is that it may cause a rapid heart rate if it causes pre-excitation. So those people who've been diagnosed with WPW or LGL maybe on calcium channel blockers or medications to help keep their heart rate slow. Treatment, if you have AV reentrant tachycardia, is exactly the same as all other supraventricular tachycardias. Now here what they're saying is that if you believe that what you've got is AV reentrant tach, and the only way you're going to know is with a 12-lead ECG, and you're looking for a slurring or a delta wave, or you're looking for a non-existent PR interval, or a PR interval less than 0.12 seconds. If you think you've got AV nodal reentrant tachycardia, AV reentrant tachycardia, they don't want you to administer medications like adenosine or calcium channel blockers. They don't want you to administer medications that slow conduction through the AV node because that can cause asystole, that can cause an extremely slow heart rate. So typically we're not able to diagnose this AVRT from any other supraventricular tachycardia unless we know what we're looking for. So what most people will do, and what certainly is allowable, is that if you've got somebody with a supraventricular tachycardia, a normal width QRS tachycardia that is greater than 160, that could be atrial tach, could be atrial fib, could be atrial flutter, could be AV nodal tachycardia, could be AV reentrant tachycardia. You don't know because everything is so close together on the paper that it's okay to give them a medication that blocks conduction through the AV node like adenosine. Adenosine has such a short half-life that if it is going to cause a problem with AVRT, it is short-lived. And should it cause a problem requiring you to increase the heart rate or pace, you've got them already hooked up to a heart monitor and you can address that. Synchronized cardioversion. We're going to use this. In fact, we use it too little. We don't use it enough. If we've got a person with serious signs and symptoms who's fixing to die, we need to consider synchronized cardioversion if their heart rates are really, really fast. We're going to give them some oxygen, start an IV. We've already got them hooked up to a heart monitor. We're going to place the patches on the chest like we do for defibrillation. Might have to shave, might have to wipe the skin down to remove the oil and dead skin to get good adhesion with the patches. Select the sync mode on the monitor, and then this is a step that you have to do each and every time you synchronize CardioVert, because when you press the sync mode, there's going to be a marker that shows up on top of the QRS, and this is the monitor identifying where on this complex it's going to deliver the shock, because when we defibrillate, the shock is just delivered immediately when we push the button. When we synchronize CardioVert, we're synchronizing the shock. So you press the sync button, it marks the QRS, that's how you know it's on and working. Once you shock somebody, once you synchronize CardioVert somebody, that sync goes off, and you have to turn it back on each and every time you synchronize CardioVert. If the patient is awake and time permits, sedate them, and then you have to select the appropriate energy level. And to keep it simple, for narrow, normal width QRS complex tachycardias, we start at 50 joules. And for wide, abnormal QRS tachycardias, we start at 100. And the reason for that is wide, abnormal QRS complex tachycardias are more lethal and they are harder to convert. So we start with a little higher energy level. You charge the machine, you tell everybody to stand back. One of the things that the American Heart Association has advocated and is rarely ever done is to remove flowing oxygen away from the chest when you do defibrillation or synchronized cardioversion. There have been a couple couple reported cases where a fire has actually started when a spark occurs, which lit some fringe of a cover on a person back in the operating room, and that real oxygen-rich environment just caused that flame to spread fast, and the patient suffered burns. So they tell us to make sure that we shut the oxygen off, or if we're bagging them, to remove the bag valve mask away from the field of electrical therapy. Press and hold the button until the electrical charge is delivered. You'll see the patient jerk. They may shout out if they're not completely sedated because it hurts, and you'll need to reassess, and if they're still in that rhythm, just push the sync again, go up to whatever the next energy level is, and keep repeating that process until they're out of that fast heart rate. Some other atrial dysrhythmias include atrial flutter. Atrial flutter, the rate is 250 to 450 a minute, typically around 300 beats a minute, so it's fast. So this, the ventricular rate, the QRS complexes are going to vary, and that's determined by that AV node. You know, the AV node usually isn't going to let more than 180 beats a minute go through. So the ventricular rate, the QRS complexes that you see with your atrial flutter, can be a normal rate, or they can be a slow rate, or they could be really fast. So the ventricular rate is going to vary. The rhythm is usually irregular or regular, depending on, again, how many impulses the AV node is letting go through. The atrial rate is going to be nice and regular. P waves are not identifiable, but what you'll see is a sawtooth flutter wave. So there is no PR interval. The QRS width should be maybe a little wider, especially if there's some sort of conduction delay, but not too wide. There are two types of atrial flutter. There's type 1, which is caused by a reentry phenomenon. The impulse circles around a very large tissue area of the atrium, causing this classic sawtooth pattern at a rate of somewhere between 250 and 350 beats a minute. If you look at that, somebody might look at that and they're saying, oh, well, the rate is regular. The rhythm is regular. The rate is 300, 150, 100, so the rate's 100. The rhythm is nice and regular. And they may be calling those complexes ahead of each or before each QRS a P wave, and they might call this sinus tach. But what you can clearly see is if I were to remove all those QRS complexes, I would see a clear sawtooth pattern that looks like the teeth of a saw blade. And that is my clue that I'm dealing with atrial flutter. Okay, there's that sawtooth pattern. If I remove those QRS complexes. Type 2 atrial flutter, the rate's faster than type 1. The atrial rate. The ventricular rate is going to vary. That could be slow, could be normal, could be up to 160, 180 a minute. Hypoxia causes atrial flutter, pulmonary embolism does, chronic lung disease, mitral and tricuspid valve, stenosis or regurgitation, pneumonias, ischemic heart disease. It's a complication of an MI as well. Cardiomyopathy, or an enlargement of the heart muscle. Hyperthyroidism. Certain drugs can cause atrial flutter, like digitalis or quinidine. Cardiac surgery, and then any inflammation of the lining of the heart or the heart muscle itself can cause atrial flutter. Atrial fibrillation, the atrium are fibrillating, just like when the ventricles fibrillate. But with atrial fibrillation, the atrial rate is extremely fast. The ventricular rate could be slow, normal, or fast, depending on how many of those fibrillatory waves actually get through the AV node and into the ventricles. There are no P waves. There are fib waves. very erratic, very chaotic, sometimes a wavy baseline, sometimes just a thick baseline. So here when I'm looking at this rhythm, there is no PR interval because there aren't any P waves. The QRS width is normal, and as I look at this rhythm, I can see that the rhythm is irregular, and there's no regularity to this irregular rhythm. So this would be irregularly irregular. There's no wallpaper pattern. There's nothing I can pick out. There's no rhyme or reason when these QRSs show up. So the rate varies. The rhythm is irregularly irregular. There are no P waves, so there is no PR interval. But what I am seeing are very chaotic waves. Sometimes I can pick up a T. Sometimes I might think I pick up something that looks like a P wave. But remember, a P does not a rhythm make. So as I'm looking at this, it's irregularly irregular. There are no discernible P waves. The issue with atrial fibrillation is how fast is that ventricular rate? Same thing with atrial flutter. How fast is that ventricular rate? We say that if the rate is between 60 and 100, then it's controlled. And oftentimes a person in controlled atrial fib or atrial flutter have no idea they're in that rhythm because the QRSs are occurring at a rate fast enough to maintain a good blood pressure. But when the ventricular rate of AFib or AFlutter gets less than 60, they may become symptomatic. If it gets greater than 100, they may become symptomatic as well. So when a AFib, AFlutter is less than 60 or greater than 100, we call that uncontrolled. With atrial fib, you've got irritable sites in the atrium firing at a rate of 400 to 600. The atrium are just quivering. Therefore, the atrium are not contracting like they should. You get a decrease in stroke volume, you get a decrease in cardiac output, and you lose that atrial kick. You lose that 30% extra blood flow because the atrium aren't contracting at all. And the other big problem with AFib is that because those atrium aren't contracting, blood just kind of swirls around inside the atrium. And as it swirls around inside there, it actually stagnates and settles, and clots are developed. So people with atrial fib are at a greater risk of pulmonary embolus and stroke, because if those clots break free and travel out the right atrium, they can get lodged in the pulmonary circulation. If they come out of the left atrium and get pumped out the left ventricle, they can end up in the head, causing a stroke. Atrial fib, sometimes it's idiopathic. In other words, there's no clear cause. They don't know why it occurs. It also can be related to hypertension, ischemic heart disease. 70% of the people over 70 are in atrial fib. So advanced age is a real common cause of atrial fib. Rheumatic heart fever, cardiac cardiomyopathies, heart failure, congestive heart disease, sick sinus syndrome, WPW, pericarditis, myocarditis, endocarditis, any of the itises. So you can see that atrial fib is just most commonly associated with aging. Pulmonary embolus, chronic lung disease, diabetes, stress, sympathomimetics, chemicals or drugs that mimic stimulating the sympathetic nervous system, things like caffeine, nicotine, hypoxia, hypokalemia, hypoglycemia, infections, hyperthyroidism, electrocution, all those things can cause atrial fib. Again, because the atrium aren't fibrillating and cardiac output drops, you can get lightheaded, pale, sweaty, chest discomfort, short of breath, low blood pressure, palpitations. You may feel the irregular heartbeat because of how irregular it can be. But if that rapid ventricular rate occurs, then it can get beating so fast that we can't tell it apart from any other rapid rate. And it comes up then to be a supraventricular tachycardia. There are 2.5 times greater risk of stroke if you have atrial fib. treating it really depends on how fast the rate is. If the rate's controlled, they often don't treat it. But if the rate is too fast, they have to slow it down. If the rate is too slow, they have to speed it up. It also, treatment depends on the general health of the individual. Sometimes if it's a treatable cause and we fix the cause, the atrial fib goes away and there's no need for medications. And then rhythm toleration. If the patient tolerates it and doesn't have symptoms with it, then it doesn't need to be treated. When they do treat it, they look at things that slow conduction through the AV node, because the atrium are firing at a really fast rate. And if the AV node starts letting those through really fast, that's where it becomes uncontrolled and symptomatic. So things like calcium channel blockers, beta blockers, and DIG. Junctional dysrhythmias, and then this will wrap up the presentation for the first part of dysrhythmias, is junctionals. Now, when we have a junctional dysrhythmia, what we're referring to is the AV node being the pacemaker. Junctional rhythms occur when the SA node fails to discharge, or the SA node impulse is blocked, or the discharge of the SA node is slower than what the AV node can do. Remember, the SA node fires at 60 to 100 normal, and the AV node fires at 40 to 60. Well, if you've got a sinus bradycardia in the 30s, the AV node may take over as the primary pacemaker. The issue with, or not issue, but one way that helps identify that this is in fact a junctional rhythm is that because the impulse originates in the junction, the electricity has to travel backward or back towards the SA node to cause the atrium to contract. And because it has to travel backwards, the P waves are inverted. So the P waves are below the isoelectric line instead of above the isoelectric line. The P waves also can be biphasic. The P waves can be in the QRS complex, or they can occur after the QRS complex as well. If we do see a P wave, the PR interval is often less or shorter than normal. If the atria and ventricles depolarize at the same time, that's where the P wave would be visible. If the atria depolarizes after the ventricles, the P wave is inverted and will appear after the QRS complex. So if we look at the very top rhythm, what we can see here is an inverted P. So the P wave is inverted before every one of these QRSs. And it does cause a little delta wave that you can see there, but the reason this isn't WPW is the P waves are inverted. Now, if those P waves would have been upright and rounded with that little delta wave, then we'd have WPW. But in this case, it's a junctional rhythm because the P waves are present for every Q. The rhythm is regular. The P waves are present for every QRS. They all look alike, but they're all inverted. The QRS width is normal. The PR interval is less than 0.13 seconds or 0.12 seconds, or less than 3 small squares. So this is coming from the AV node. And in this case, the atrium depolarized before the ventricles. In the second strip, the atrium depolarized after the ventricles. So you can see the P wave shows up after the QRS complex. Prior to the QRS complex, there is no P wave. But after the QRS complex, you can see an inverted P, and then the T wave following the P. So that second rhythm, the rate is slow, 300, 150, 100, 75, 60, 50. The rate's about 52, 54. The rhythm is regular. There are no P waves, so there really isn't a PR interval because there aren't any P waves before the QRS, but what I am seeing are inverted Ps after the QRS. This is a junctional rhythm as well. And if you look at that very bottom strip, there are no Ps at all. I just have QRSs and Ts. And because I have no P waves at all, that's telling me the ventricles and the atrium depolarize at the same time. And the electricity generated by the ventricle depolarization obscures the electricity or hides the electricity of the atrium. PJCs, as it sounds, or as we break this down, premature junctional complex. It comes early. It originates in the AV node. So again, this is going to have a P wave that's inverted. It's not going to have a P wave, or the P wave may be after the QRS. It just comes early. PJCs are caused by the same things that cause PACs: heart failure, acute coronary syndromes, mental and physical fatigue, valvular heart disease, digitoxicity, electrolyte imbalance, rheumatic heart disease, stimulants like caffeine, nicotine, codeine, all those. So here is an illustration of some PJCs. If I look at this rhythm, and I want to know, is the rhythm regular or irregular? It's irregular. And I'm not sure what the irregularity is yet, but it doesn't look nice and regular. And as I kind of march stuff out, I can see the distance between the third and fourth complex on the strip is my normal underlying rhythm. That should be the normal distance. So that second complex is premature. That fifth complex is premature. That eighth complex is premature. The 11th complex is premature. So I've got these premature complexes in here, and I need to know whether they're PACs, PJCs, or PVCs. And I can see clearly that with that second and fifth, eighth, and 11th complex, there is a P wave in front of those QRSs that come prematurely, and it's inverted. So that tells me those are coming from the junction. With premature junctional complexes, the rate is usually within the normal range, but it may depend on the underlying rhythm. In this case, the underlying rhythm was a sinus rhythm almost at a rate of 100. The rhythm is regular with these premature beats. The underlying rhythm is regular, but it includes these premature beats. There is a P wave before, during, or after the QRS, and it's inverted, or it's absent. If there's a P wave before the QRS, the PR interval is usually narrow. The PR interval is usually short. If there is no P wave before the QRS, obviously the PR interval isn't present. The QRS should be normal width because once it leaves the AV node, it travels the normal conduction pathways and should cause a normal depolarization of the ventricles. With a junctional escape beat, this occurs when the SA node doesn't fire. The rate is usually within normal range. It depends on the underlying rhythm. The rhythm is regular with these late beats. Again, it's a junctional escape beat because we'll see that there'll be a long pause because of sinus arrest, and then the AV node just decides to fire because it's waiting and waiting and waiting for that impulse from the SA node, and it never comes, so it fires on its own, causing a junctional escape beat. Now you can also have a junctional escape rhythm or a junctional rhythm, but that would begin following documented long pauses of sinus arrest. PR interval, if a P wave occurs before the QRS, the PR interval is going to be short or not as long as it normally should be. No P waves before the QRS, PR interval it's not present. If there's no P wave, there's no PR interval. The QRS duration should be normal. So here we go. We've got the first and second beat is our underlying rhythm, as well as the fourth and fifth. So the first, second, fourth, and fifth, that's our underlying rhythm. And we can see a really long pause between the second and the fourth complex on that strip. Now that third complex, it's not premature, but we need to identify where is it coming from. If that third complex was coming from the atrium, there'd be a P wave. If it's coming from the junction, there may not be a P wave, or the P wave may be down there after the QRS. And that's what I suspect I'm seeing, is the P wave is after the QRS. So this would be a junctional escape beat. Junctional escape beats or rhythms are usually 40 to 60 a minute, because that's how fast the AV node will pace the heart. The rhythm is regular. Again, P waves may be before, during, or after the QRS. They're usually inverted if you do see them. Again, if the P wave occurs, your PR interval is going to be short. And no P waves before the QRS, there's going to be no PR interval. The QRS width should be normal unless there's some sort of conduction delay. Junctional escape beats causes would include those things that cause the misfiring or the lack of discharge of the SA node. Acute coronary syndromes, hypoxia, rheumatic heart disease, valvular disease, SA node disease, sick sinus syndrome, increased parasympathetic tone, cardiac surgery, medications. Now, the junction normally fires at 40 to 60, but it can fire faster, just like the SA node fires 60 to 100, but it can fire faster as well. And when we have the AV node as the primary pacemaker of the heart, and it's firing faster than 60, but less than 100, we call that an accelerated junctional rhythm. Now here you see on this strip, I have a rhythm that has a rate of, the rhythm is nice and regular. The rate is 300, 150, 175, 60. The rate is somewhere around 72. So I got a rate of 72. The rhythm is nice and regular. I don't see any P waves before those QRSs. There may be a P wave at the end of the QRS, and the T is inverted below the isoelectric line. So this would be a junctional rhythm, but it's beating faster than 40 to 60. It's not tachycardic, because it'd have to be greater than 100 to be junctional tachycardia. So we just call this an accelerated junctional rhythm. 61 to 100 beats. The rhythm is nice and regular. The P wave may be before, during, or after the QRS. It may be inverted. Short PR interval. No PR interval if you don't have a P wave. The QRS width should be normal. Causes, just like all of them: digitoxicity, acute MI, surgery, rheumatic fever, COPD, hypokalemia. Now with junctional tachycardia, this is an ectopic rhythm that begins in the pacemaker cells in a bundle of His. It may be the result of 3 or more sequential PJCs in a row that set off this ventricular rate greater than 100. Causes of junctional tachycardia include acute coronary syndromes, heart failure, drug toxicities like theophylline and DIG. As with all tachycardias, we begin to treat those the same way. If it's greater than 160 and it's causing symptoms, then oxygen, IV, vagal maneuvers, adenosine, beta blockers, calcium channel blockers, synchronized cardioversion. Again, with the junctional tachycardia, the rate's between 101 and 180. The rhythm is nice and regular. The P waves are going to be before, during, or after the QRS. The PR interval is going to be short, and the QRS width should be normal. So as I look at this, the rhythm is nice and regular. The rate is 300, 150, 100. So the rate is 130. So the rate's 130. The rhythm is nice and regular. I don't see any P waves, or if I do, they're inverted right before the QRS. So I may have some inverted P waves right before the QRS. So this tells me this is coming from the junction. It's not beating 40 to 60, so it's not a junctional rhythm. It's not beating 60 to 100, so it's not an accelerated junctional rhythm. It is greater than 100, so it's junctional tachycardia. All right, so that ends our discussion of the atrial and junctional dysrhythmias. I'm going to stop here because it's been a little over an hour, and I'll start back up again with another talk on the remaining cardiovascular dysrhythmias, which include things like the ventricular arrhythmias, VTAC, VFib, other cardiac arrest rhythms, as well as the blocks, the first degree, second degree type 1, type 2, and third degree AV blocks. So talk to you soon.